Good morning. So my name is Nicholas Szerlip. I'm a professor of neurosurgery at University of Michigan and the director of the spinal oncology program. And I'm very pleased to be here this morning involved in the AANS neurosurgery fireside chats without the fire because we're in the hospital. So that wouldn't be great, but with one of my most influential mentors, Russell Lonser. Russ is currently the chairman of neurosurgery at the Ohio State University. And this is the only venue I think where you'll see an amiable conversation between Ohio State and Michigan. So hopefully we'll have many more with the Neurosurgery Consortium starting, but for now, this is as good as it gets. So I want to lead into, Russ, you've done some amazing things in neurosurgery, and I want to ask a ton of questions, but I want to ask a few questions so others can not only hear your story, but learn from your model of success. And so I'm going to break it up into eras, kind of Taylor Swift style. And I know you have a daughter, so I know you know who that is. Kind of start at the beginning and move forward in your career. And so the first kind of question is, what were some of the salient experiences in your life that led you to neurosurgery?
Yeah, Nick, that's a great question, and it's always good to see you. So I think there were several, salient events, and it first started out in med school. I didn't know, early on what I wanted to do. I knew I wanted to do surgery, something that was technical and that was active. And I didn't know what type of surgery I wanted to do. We had some good friends, a good friend of our family named Rich Wise, famous neurootologist in Chicago. And I spent some time with him. And I also got to interact with neurosurgeons very early on through that interaction with Rich Wyatt. That really convinced me that I wanted to do neurosurgery because of all the facets you could do in this field, from spine to functional to tumors to trauma, all of those things. And then I spent some time with, Ed Oldfield during residency, and Ed super well as well. You spent time with me and Ed. And I spent 2 years at the NIH with him, and that really changed my life in the sense of wanting to do research and seeing the opportunities of what you could do in neurosurgery. And then I returned after finishing residency in Utah to the NIH's faculty and spent, well over a decade there. And so it was those little points in time where, in working with individuals that were really excited about what they were doing, seeing the opportunities in the field, and then working with someone like Ed, who was convicted to changing the field and research, and finding that was really, really exciting. I didn't, never along my way did I have a preconceived notion about what I would do, and just kind of let opportunity, and passion, I know that's used a lot, dictate how my career and things like that would go.
So you talk about Ed, who was an amazing mentor as well, and you obviously learned your mentorship skill from him as well. And I'm sure that's probably the answer to this question, but kind of what made you go to the NIH and what inspired you to take that position? And then how did that position and working with Ed shape your view of neurosurgery at the time?
Yeah, so how I got into that fellowship during, you did enfolded fellowships during residency. You did one, you did an, incredible job. And I think that, shapes what you're doing today. You could probably answer the question in the same way I would. I didn't know what the NIH was. I had heard of it. I was flipping through a journal of neurosurgery and saw an ad. And I remember, in those days, you left a phone message or, called his assistant. And I literally got a call back while I was dictating an op note, a day later. And, I thought, what a great opportunity. I knew they did a lot of research. I just didn't know, exactly what types they did. And I, had the opportunity to go out there. And so that was, that's kind of how I got introduced to it. And then, spending that time there and seeing the exciting things you could do, with drug delivery. I mean, you've done great things in drug delivery as well. And it was looking at, how do you take the substrate of patients that you have and data from that and ask very simple questions. And that's what Ed always, thought about. It wasn't some complex, multi-layer issue or question that he was asking. It's just ask the simple things like what impacts a practice. And so, learning from that during that period of time, I wanted to come back. There was a very unique practice in there, with neoplasia syndromes, NF1, NF2, von Hippel-Lindau disease. I wanted to do intramedullary spinal cord and brainstem tumors. And those just don't, you don't get those every week in any academic practice. But back at the NIH, as you know, we literally got them every week. And so it was all of those different types of touch points and experiences that, really led me to go back there and, continue along those lines, but ask really simple questions, keep things simple. Do patients do better? Do they do worse? Kind of get to really what's important in a patient's life and in a surgeon's life in research.
Yeah, and that's, when I worked with you, that was the most impressive thing about you and Ed to me. Like I wrote up all these questions last night, and it's like going right down the same way, And you're both of you, Ed and yourself, were such great technical surgeons. And you always had an eye on research, but the research was, like you said, very simple but profound. Like simple to like a surgeon who doesn't have a research, I guess, like brain, like it's not like the protein folding of this or that. It's like a simple question that has a direct impact on patient care, patient lives, and patient outcomes. And I thought that was the most phenomenal thing when I was at NIH. We were always asking big questions, but also the simple questions were the most important ones. And so how do you see the line, now in your position now, how do you see the line between neurosurgical clinician and scientist? And how should neurosurgeons best walk that line as a physician scientist? And how do you determine that for your faculty?
That's a great question. And I know, the answer as well as anybody to this. And I think it's really what it is we have a unique opportunity as surgeons, neurosurgeons in particular. We meet patients that need and don't need surgery. So it gives us an opportunity to look at natural history. We have the ability to access brain tissue, brain substrate, fluids, things like that others can't do, and get direct information. We have the ability to get physiologic data directly from the deep brain and structures in the brain itself, generally, spinal cord, things like that. We lead multidisciplinary teams because of that ability. So I think it's, the interesting part about that is we've got to remain focused on the broader things, like what will make a patient's life better? What are the simple questions rather than getting complex? And I'll give an example of, you were there when we were trying to figure out how do syrinxes and cysts form? Seemed just a basic question. And, spent time, effort, imaging, all the things that we collect in the clinic to kind of derive how these peritumoral cysts with hemangioblastomas form, with metastases, things like that, and how are they differentiated from gliomas and other things, with necrotic cysts and things like that. But a very simple question, but led to the understanding of how radiation and chemotherapy can affect symptoms without actually having impact on the tumor mass itself. So things like that, you're just watching in the clinic and you're, asking these really simple questions. I think that's where the surgeon scientist can do things. Now, there will be folks that will come in and they will run a lab and they will look at these, very important proteins and genetics and things like that. That again, we have access to the tissues and things like that and we learn from our patients and things like that. So I think, that we are really, if any specialty have the unique opportunity to do that, but we really also have the opportunity to look for the basic questions, and answer them in a very direct way.
Yeah, I totally think that is, kind of like there's a role for everybody. There's a role for the person in the lab and a role for the person on the ground. And being able to integrate the two, I think, is the key to being a physician scientist in today's era. So your path has been a little unorthodox because you spent so much time at NIH. And NIH is such a unique department. I remember talking to Ed about it when he went to Virginia, how different it was when he went there. So how did you make the mental transition from NIH to chairman of Ohio State, where the goals and objectives on the surface seem very different at those places? So first, are they that different? The department objectives, and then kind of how did you make that transition, and what was your mindset coming into the current role that you have?
Yeah, that's a great question. And I think in the way you phrase it, I think you're right. I think you answered that question at some level. Is I don't think the goals and objectives are different. There's different drivers and things like that. Whereas, RVUs and things like that will impact, some of the decision making that occurs in an academic department versus the NIH, where RVUs and things like that weren't accounted for. But you were there, our volumes, Ed and I both surgically had large surgical practices while we were there. But that was absolutely critical for us understanding the disease. We couldn't live remote in a lab without, experiencing the patients. And I don't think Ed and I, neither one of us had what we call a traditional basic science lab. In fact, as it was translational, and the vast majority of work that was also done was our laboratory was the clinic and the operating room. So we were very defined about what we wanted to do, the patient populations that we wanted to see and understand. So that goes to, when you translate that to an academic department, that's subspecialization that occurs. So you don't have, you as a phenomenal spine surgeon aren't clipping aneurysms at night and things like that. And the vascular folks aren't doing the complex spine you're doing, and on and on and on. So first and foremost is remaining within those subsets that you're studying those patients and taking care of those patients in a very defined way. You're understanding them in large volume. So volume is important. I think the other point is understanding that not all surgeon scientists, run a laboratory. I think the vast majority of surgeon scientists are, starting first in human trials, running multi-center trials, looking at device development. Looking at physiology, where your operating room is your laboratory. And we need to think about it that way. And patient care and all of those things are really, really important. And some people will have, an effort in a lab that are neurosurgeon scientists, but they will use probably tissues and things like that that they derive from, or physiology that they derive from epilepsy, deep brain stimulation, tumors, and things like that. But saying that, those same functional surgeons and tumor surgeons can do remarkable things in the clinic. And you saw that at the NIH. A vast majority of our work was done in the clinic and the operating room. So I don't think it's very different at all. Or there's very few differences. The same drivers at the NIH, specialization, clinical volume, and all of that are just as critical as they are in academic practice. So very little difference, Nick, to be honest with you.
So taking those goals and implementing them in your current position, it's been one of the biggest turnarounds I think I've seen in a while of a department. And Ohio State's always been a great program, but just a trajectory that you set them on with NIH dollars, outside research funding, not just, delineating there's more than just NIH, research dollars, foundation dollars, industry dollars, and building that program on kind of all the different levels. Where did you learn that? Because, not only hopefully just residents will watch this, but also junior attendings who may aspire to be a chairman. Where did you get that acumen on how to build such kind of a powerhouse program? Did you lean on certain people for advice, or did you just kind of figure it out yourself?
No, I mean, it was, it was Ed, to be honest with you. Ed understood that, that there's no pathway. You take Ed, who was in private practice after he finished residency, right? You talk about an unusual pathway. 2 years in private practice, goes to the NIH, tell the story. He didn't even know what the NIH was. Never had heard of it till he started looking around, ends up there. Actually, they don't pay him for several months because they didn't actually have a job for him. But what all that was he understood what he was passionate about. He was given the tools, the ability to do that at the NIH. And there was no, preconceived pathway that he follow. Because, particularly in today's environment, you can't say you're a surgeon scientist only if you have NIH funding. It's not true. More and more surgeon scientists are going for foundational, industry, and other federal state type funding mechanisms that are just as valuable. And so saying that, you can probably sort out the specialties that will benefit and can move the innovation faster. Some of them will be tied to the NIH. Functional tumor, naturally lend themselves to, but both those things also lend themselves to clinical trial device development. It'd be far harder to do with federal funding at times than it is to do with foundational or industry support in defined ways in those areas. Spine, another example. I would uh, hazard to guess. You could move far faster in the innovative work you want to do, rather than waiting for some federal grants and waiting for the RFAs, RFPs to come out. You can probably move the dial faster with institutional support, industry support, and other things. And it goes on and on and on. So and individuals are different within those spaces. They have to find the pathway that they're going to be most happy at and where they're feeling the most reward. You can't force a surgeon to say, well, I only value this type of funding and support and only this type of research. That will die. We have remarkable faculty here like you do up at Michigan. My view has always been, like Ed was, just turn them loose. Give them the opportunities. A handful will fail, but the vast majority will be wildly successful.
Yeah, that's a great outlook. And honestly, I can feel the passion, you use that word, that you're talking about your department with. Is what drives you every day, to get up, and we all have bad days, especially in patient care, to get there the next day and just do it again. What is that underlying? Is there an underlying goal? What is?
It's a great question because I think it evolves over your life. Look, you're a professor there. You've done all these remarkable things, and I think you would argue in your own career path, you've seen it. I think making these transitions, from moving from a staff clinician at the NIH to the branch chief, you moderate your goals, and then moving to chair, and then you moderate your goals. But I think more and more you look at the long play, the 3, 5, 7-year things, because being a chair now, you don't get. Whereas, if you're in the lab and you're doing very defined research, you may have a win every couple of weeks, some incremental gains. Whereas in a department or as a chair of a department, you're looking for the 3-year gains. What happened over 3 years? Did we make the right decisions, 3 years ago that are paying off for us today? Did we make the right decisions 7 years ago? So those are the wins at the end of the day. It's just reflecting back, and it's hard, like you say, like driving in some days, you're wondering, geez, the dial didn't seem to move much today or in the last month or the last year. Are we doing the right things? Those are the things that keep you up at night, but you're doing that throughout your career. But the delayed, whatever you want to call it, gratification or whatever, becomes even more delayed as you move through the process. You just got to get comfortable with that.
So what advice would you give, taking it in 2 parts, what advice would you give residents right now going into neurosurgery, to kind of aim their career if they want to do academics? And what advice would you give junior attendings?
Yeah. And it's going to sound like cliche almost, right? Figure out what you're passionate about, what makes you happiest. That's first and foremost. Second thing is don't have geographic constraints. The best job, look, I never lived in DC except as a fellow. My wife's from Los Angeles. Never in a wildest dreams did we think we were going to move away from our families. We just had my first daughter, just as I was finishing up, moved away from, thousands of miles away from family. But that was the right job for me. It wasn't the easiest job for me we didn't have, family support around the corner. My wife is working, still to this day as a physician, was working full-time then. So we had to manage all of these things. So, but just go for the best job, no matter where that's at. I think the third thing is always be able to adapt. Look, drug delivery and neoplasia syndromes were things that interested me, but I didn't know that when I was in residency. I didn't know that as a med student, but I also saw an opportunity there and moved to that and, continued to walk through that pathway research-wise, which was remarkable. I could never have figured out that journey. And I think, the fourth thing that will also sound cliche is it's really the journey, not the end result. There's going to be hard days in neurosurgery when you go to work, just like anything. But I can tell you every day, if you feel like you're making incremental progress, you will be rewarded at the end of the day. It's not a grant or a paper published. Those are really important milestones or a title or things like that. It's really everything you've doing along the way. There's tough things, but you're still excited about seeing those spine patients, at the end of the day. You're still excited about a complex spine surgery. A lot of people in life don't have that opportunity. They're driving to work. They don't get to do the incredibly interesting things we get to do.
So you talked about your wife, and she's an amazing person, but just like you are, how do you balance? Because a lot of residents are always asking this question to me, and I think it is important now with this next generation coming up. How do you balance life, work in general, and through the stress of neurosurgery? Do you leave it at work? Do you bring it home? Like things like that. Is it something you talk about a lot at home? Like, how do you balance all those stresses?
I will say this, Dick. I think every, you know, partner dyad will be different. And I think that's something where the only thing that, or the only advice anybody could give is make sure you're communicating about how you want that to be set up. I don't bring work home, at least in an overt way. It may be, my subconscious and things like that. When I go home, my wife and I, aren't talking about neurosurgery. I don't think she has any interest in it, to be honest with you. And she's an OBGYN, as you know. I'm not talking about OBGYN, patients with her. I think we're talking more about family, but that may not work for every partner diet. I think it could be very different where some people want to talk about their work and their issues all day. I just don't want to rehash them. It's something I just, but that's my personality. I can cut that off when I leave the door and never think about it until I have to come back and think about it. But that may not be the right thing for everybody.
So we're talking about Ed a lot, and how he's affected both of us greatly, and his legacy. What do you see as your legacy? What do you want to be your legacy 10, 20 years from now, when we're talking and somebody's talking about you?
Yeah, no, I mean, that's a really, really hard question because, as you know, I think particularly in neurosurgery, a lot of us are consumed with the word legacy. And I think if you look back historically, there would be people that did not work with Ed, or people like you and I that did work with Ed, and that will be a big part of his legacy. The people you work with and I work with will be a big part of our legacy. Those will be the people that understand, because as as new residents come on, and individuals that retire or pass away, there's no way to keep that knowledge or information tied to that person. I mean, other than the publications and things like that, but it's put in a textbook and things like that. I think what it really was, and I think Ed would say the same thing to both of us, that really is really do be in the moment, do the things you think are important. You will carry your legacy internally to you, but it will also be the people you trained. It will be the concepts. Ed used to use that word of concepts. It'll be the concepts that you change. On the other hand, don't think that every concept is going to be tied to Szerlip, Oldfield, Lonser. Understand that that's not the end game. It's the joy of figuring these problems and questions out will be the legacy, along with the trainees at the end of the day. I don't think it's not going to be a title you or I or Ed ever held. It will be, Chiari. We were just at the academy. Fred Meyer talked about, the concepts and physiology that Ed discovered around Chiari malformation. Again, seemingly a simple thing, but boy, he radically changed how those patients are managed at the end of the day. That will be
the best legacy is the one raising a toast to a shot of whiskey.
You know what? Probably the best legacy will be all the lives that he changed. I mean, you look at the Cushing's spinal AV fistulas, Chiari, where he really did radically change the care for the better in those patients. That's really, I think all of us aspire to have that type of legacy at the end of the day.
Yeah, definitely. So I want to finish up with one kind of finalist question. So you've been president of societies, chairman of the neurosurgery department. Is there a next challenge that you have? What is, or is it just going to be more, just like you said, live in the moment, or do you have something further sights, or you're just enjoying what you're doing?
Nick, I've never been one, nor will I be one, to aspire to some other senior administrative role. What is more exciting than doing neurosurgery and researching neurosurgery? I mean, yes, there's these other titles and roles that has never crossed my mind as interesting.
Yeah.
I would rather be in an operating room. I would rather be seeing patients. I would rather be doing research. And just as importantly, I'd rather see faculty and residents really having the opportunity to do things that are unique and important in the field. There's nothing that interests me more than that, and that won't ever change. I hate to say it. We're all you're wired this way. I'm wired this way. A whole bunch of neurosurgeons out there are wired this way. Because that's, I mean, what else? How could it be more exciting to sit through, 7 days of meetings all day long? I don't versus what we can do in an operating room with patients, with trainees, and all that. Doesn't even compare.
Definitely. I think that's all the questions I have. I mean, obviously, we could talk for hours about a million things, but if you want to mention anything you think anybody else would be interested in, we can talk about hobbies and whatnot. But I think
it's just, you know what? It's the good things. It's always great, seeing you, all the success you've had, and all the success you're going to continue to have. That's all I would say is that those are the important moments.
Well, thanks for talking with me. This is often better done over, like I said, a glass of wine or whiskey. But, but Zoom is fine too.
So great. It's good seeing you, man.
Yeah, no problem. So, and I guess we'll end it there. Is that